Well, welcome here, everyone. I know people are still trickling in, so we'll give it a couple minutes. Want to make sure everybody has a chance to catch everything that you have to say there, Thivia. We'll wait till 12:02. It seems like an auspicious number, but it seems like the flood is slowing to a trickle, so maybe we'll get started here. So welcome everybody to today's Ethics for Lunch session. We're really excited to be hosting our speaker, Dr. Thivia Jegathesan, as she discusses an intersectional approach to patient narratives, systems, and evolving language. And before we get started here, so I'm Tyler Paitko. I'm one of the clinical ethicists here at Providence. And just want to start us off in the right way here and note, I had the privilege of moving to Vancouver in 2023, and now I get to live on the ancestral unceded lands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I also have the privilege to work in healthcare. And I think it's really easy for us to lose track of how incredible privilege both of these things are, and for these things to become routine. But I think it's really important to not let it become that way. So, in particular with the land acknowledgement, getting to live here is really an incredible privileges. And, these land acknowledgements have become, and for very good reasons, are things that we've integrated into, how we start most of our meetings and presentations and everything. But I think when we do that, it can often it can become easy to lose sight of why we are doing them. And I think it's really important to use those opportunities to step back and really reflect on and acknowledge, why we've started doing them, and to acknowledge the people that have stored these lands for so long and continue to do so. Right? It's easy for these land acknowledgements just to become a checkbox and be like, oh, look, we've done our part for truth and reconciliation. But it's so important to remember, why these are needed in the first place. It's so important to acknowledge that these are just one of the easiest recommendations to fulfill that came out of the TRC. And, it's really important for us to reflect on, what do we mean when we're saying unceded and ancestral lands, and the harms that have led to these land acknowledgements being important. I think it's also an incredible privilege to work in healthcare, and it's important to take a step back and acknowledge that, and also really connect that with the land acknowledgement. Right? As healthcare providers working on these lands, I think it's so important to recognize the systems and the institutions that we operate within, and how those weren't really originally, they weren't built to serve everybody equally. Indigenous people in these regions have experienced the harms of colonial healthcare, from, segregated Indian hospitals to the systemic racism that continues to shape health outcomes today. And it's really important that when we're acknowledging the territory, that we acknowledge that history and our ongoing responsibility to work towards healthcare that, upholds the inherent right and dignity of everybody that walks through our doors, and works to both name and correct these systemic and historical harms. And I think Thivia's presentation today on patient narratives and intersectionality is a really important piece of that. And so it's really important to tie that all together. I also wanted to take a second and recognize that, February is Black History Month. And when we're talking about systemic oppression and racism and how that connects to healthcare, that that is also a big piece of it, the way that, Black people in Canada have been marginalized and how that has affected, all sorts of other communities as well. And I think this month is also a time to honor the, contributions and the experience of these communities, and also to name and confront that anti-Black racism that persists in healthcare and in society. And then finally, I just wanted to take a second and acknowledge, I said off the top that I moved to Vancouver in 2023. And before that, I had the incredible privilege of being raised in and around Grand Prairie, Alberta, which is in Treaty 8 territory. So this is the territory of the Beaver, the Cree, Dene, and Métis people. And it is, I think it's one of the most special parts of the country. And it's always somewhere that will feel like home to me. Sorry, it's getting a bit emotional, but I just also wanted to acknowledge that Tumbler Ridge is also located in Treaty 8 territory, and that's a very special community to me. It's where my grandparents live. It's where I spent every one of my Christmases and most of my summers. And, it's there's a lot of people that have a much bigger claim to that area and, to everything that's going on there right now. And I'm not wanting to center myself in this discussion, but I think it's just important to, when we're doing these sorts of events and land acknowledgements, to also share a piece of ourselves and how we're connected to these things. And I just really want to take a moment to, acknowledge the tragedy of what happened in Tumbler Ridge on Tuesday, and the pain and suffering that people are going through there, and the role that, we as healthcare workers and people in this province, have in that. And, really just to take a moment and, tell the people in your life that you love them. And, there's really not thoughts, words really fail at a time like this, but I just really want to take a moment to acknowledge what people are going through, and to, you know, encourage people to share that love and support in every way, in any way that we can. So with that context in mind, I'm excited to pass this off to Thivia. Sorry, I misplaced. Oh, here's your bio. So Thivia Jegathesan is a clinical ethicist at the Provincial Health Services Authority. Thivia is dedicated to advancing health equity, social justice, and the meaningful inclusion of patients and families in healthcare decision-making and policy. She holds a PhD in medical sciences and a Master of Health Sciences in bioethics at the University of Toronto. Before transitioning to clinical ethics, she conducted pediatric research through a health equity lens, examining the impact of health systems, practices, and policies on children from birth to adolescence. So welcome, Thivia. The webinar is yours. And I'm going to turn off my camera here so I don't distract people from your great presentation.
Thanks so much, Tyler, for that wonderful introduction. And I really wanted to acknowledge and appreciate the space that you provided for us all to reflect on the tragedy that occurred in Tumbler Ridge. And I really want to also appreciate you sharing a part of yourself, your narrative, and your vulnerability in order to build this community. And I think it's a great way to start off this talk and this presentation. So I just wanted to give space for that and acknowledge your experience as well. I'm just going to share my slides, just bear with me. trying something new, and I'm hoping that this will work. I think everyone can see my slides. So I just wanted to start off with a bit of my own land acknowledgement, because I think it's an opportunity to connect this to the talk that I'm doing and also ground myself as I go into this work. I'm joining from my home office on the traditional, ancestral, unceded lands of the Musqueam, Squamish, and Tsleil-Waututh Nations. I, like Tyler, came to Vancouver, colonially known as Vancouver, in 2024, and I'm very grateful to be able to work on these lands and build a career in clinical ethics as well. And so as we're discussing today, understanding patient narratives through an intersectional lens, specifically the relationships that we develop with diverse patients and families, and the relationships that our patients and families have with the systems and structures and institutions that we work for, it's important to remember the stories of Indigenous patients and communities and families, their experiences with racism and discriminations, inequities, and the stories that they carry when they come into our health system. When we see them, when they come into the health system, we see one of their worst points in life when they experience a health encounter. But with that entry comes a big story that we should and advocate for telling the truth of the impact of colonial violence on Indigenous people. So I'll delve this a little bit into my talk in terms of understanding their stories, dissecting them, and making that a part of our commitment to truth and reconciliation, and discussing the impacts of colonial violence, the ongoing impacts. It's also in light of Black History Month and the impacts of colonial violence on Black History Month as well. So this presentation will discuss the importance of understanding patient narratives through an intersectional lens in order to better support the needs of the communities from diverse backgrounds that we serve. And it would also highlight the evolving nature of equity terms in the language you use when we're working with communities from diverse backgrounds, whether it's within our presentations, within our talks, within our charts that we write, or within any advocacy. And I want to apologize ahead of time if I use any inappropriate terms and language in equity terms, acknowledging that equity terms are constantly evolving. They're very different according to your lived experience and your understanding and your shared narratives. And so, I'm working to better myself in using the appropriate terms and understanding the landscape that I'm working within. So I just want to invite that reflection as well. So I want to first acknowledge and sort of set the stage that the healthcare system and healthcare is a challenging experience. When we enter the healthcare system or a healthcare encounter, it's typically one of the most difficult moments in a patient's life. And it changes their lives, whether, we're walking down the street and someone experiences a heart attack, or you have a really bad fall. It changes that moment in your life. That's an unexpected moment. And it further complicated by the systems that may not always be supportive of diverse patient needs. And what we saw during and post-COVID, and with financial and economic constraints that's going on in the world, was when you're going to that healthcare encounter, existing experience of discrimination, marginalization, inequities is exacerbated in these experiences. And patients who have experienced systemic barriers continue to uncover unmet needs. And so in our role within working with healthcare, I feel like it's my responsibility to be able to maybe not be able to fix their health inequities in that moment, but not exacerbate it and make it worse, and recognize those experiences when someone is coming into our health encounter. So when patients and families are faced with an ethical challenge, it's also an even more difficult moment in their life and their experiences that were impacted. So I wanted to present a case, not necessarily to resolve or address, but to highlight how narratives and intersectionality can help us further understand a patient's story. This case was taken from Pelk et al.'s article on approach to working with at-risk patients expressing a desire for discharge. And so I'll read out this case as we're all reading it together. So Mr. M is a 17-year-old patient with some cognitive difficulties who is a newcomer to Canada, who has been admitted to a post-acute hospital for rehabilitation following surgical repair of a hip fracture. Upon admission, he was deconditioned, unable to mobilize independently, and required assistance with activities of daily living. He can now mobilize independently with a walker, but the nursing team notes Mr. M is unable to maintain adequate perineal hygiene without assistance. He is participating minimally in the rehabilitation program recommended by the multidisciplinary healthcare team and wants to go home. Mr. M lives alone in a townhome with the bedroom and a washroom on the second floor. He worries he will lose the community he has at home. While the healthcare team is encouraging Mr. M to go to a long-term care facility to meet his needs, he insists on returning home. He also has some hesitation with home care support. He values his independence and dignity, strongly believes he will manage at home, and insists that his quality of life will be substantially better than in a long-term health facility. So typically when we encounter this, and I'm sure people on the call have encountered this or something similar of this nature, of this case, whether it's supporting patient choices, supporting choices that may not be what we feel is in the best interest of the patient, or understanding different opinions and different perspectives. And typically from a Western bioethics lens, we'll look at Mr. M's case and look at his capacity to make decisions. We'll try and balance his autonomy with beneficence and non-maleficence. And while through patient interactions, we can kind of gleam into his history and story and wishes, what this really doesn't tell us is how Mr. M sees his story and situation. Why is he declining certain support? What happened before to inform his choices? What are his worries around home care support, going to a long-term care facility? Why is he not engaging in a rehabilitation program? What is the need? What is his motivation to want to go home as soon as possible? So alongside balancing autonomy and beneficence, narrative ethics can help us, or narratives can help us gain some more insight into Mr. M's story. So what is narrative ethics? Narrative ethics, and I just want to say that I'm going to do the description of narrative ethics from more of a clinical application lens. There is the theoretical, more sort of explanation of this, but for this purpose, philosophical explanation. For this purpose, I'm going to go more into how it applies to clinical lens. So narrative ethics is an approach to ethics that aims to really gain ethical insight directly from patient stories. And it focuses on our shared responsibility as a healthcare team in co-constructing a solution that's as least disruptive to the patient's narrative. So it really highlights the importance of storytelling, and it helps us unpack values, wishes, and desires in the context of the patient's story from the perspective of the patient. The storytelling process can really help us unpack the patient's story prior to this fall, what had happened. So prior to this fall, Mr. M was living independently. He had a community and was fine. It could also provide some insight into why he has some of the hesitations he has around home care support and long-term. So he highlights that he doesn't want to lose his independence. He wants to live with dignity and respect. So what is his understanding of long-term care facilities? What is his understanding of having someone come into home support to support him? What is he grappling with? The key here highlights that healthcare is a rupture in his story. And our goal when we're working with Mr. M is to co-construct a solution that's as least disruptive to his story. So I'm not saying this is the right solution or not, but we could perhaps, ask him to, figure out a way and have him go to a long-term care facility. But what is that going to do to his narrative? What is that going to do to his story? What is that going to do to his self-worth and dignity? And also, respecting that how is his life and his story going to be different when he goes back home without the appropriate supports, without the opiate rehab. So really working with Mr. M to understand how does he see this health encounter in his story, and how can we work together to support him? And so this talk will specifically focus on how an intersectional approach to understand patient narratives, where we try and understand and listen to the stories of patients, understand what brings them to this counter, and how can this process help health professionals provide a solution that is in line with their experience and is in least disruptive to their narrative. So just a quick reminder, intersectionality is a concept that's developed by Dr. Kimberly Crenshaw, a Black feminist, that identifies that our social experience are shaped by intersecting identities, social conditions, and they're interconnected, meaning we all have intersecting identities, characteristics, social conditions that make up who we are and how we experience the world. And depending on our characteristics, identities, social conditions, and the location that we're in that moment, we have different experiences of power and privilege and marginalization and vulnerability. And the key is how this changes based on the environment and situation that we're in. For instance, when I'm in an ethics consult or doing a talk, I may have more power and privilege in a different relationship with power and privilege versus if I go into a health encounter. The risk of just using intersectionality and looking at kind of the identities and intersection is without understanding a patient's narrative and the story behind it, and that's informing their experiences, it can exacerbate preconceived notions and stereotypes. So we can't just look at intersectionality. We hear this sometimes in the literature saying, this person is intersecting the identities and we need to recognize, and we kind of have like a laundry list of what their identities and experiences are. But if you don't put that in the context of a narrative, we run the risk of exacerbating any stereotypes. So my experience as a South Asian Sri Lankan Tamil person is very different from someone else's experiences, especially from the location of people that live in BC versus people that live in Ontario versus people that live in Sri Lanka. So it's really important to understand the individual's unique experiences and their identities and social conditions with that experience. So using intersectionally, we need to make sure that when we're using this, we're not perpetuating stereotypes and preconceived notions. So how do we put this all together? So some experts have explored this concept of intersectional narrative ethics. And so this is the idea of, by looking at narratives through an intersectional lens, we can contextualize the patient and family stories through an anti-oppressive and anti-discriminatory lens. It humanizes and helps us understand where the patient is coming from within their experiences, but it also brings weight to the actual story to understand how oppression, discrimination, health inequities, barriers to access to services are informing their choices and experiences. So we can look at whether their experiences of racism, discrimination, or oppression, is there a trauma response? Is there historical trauma experiences that are resulting in a response here right now, and how can we support this? It also allows us as a responsibility to look at our biases and assumptions in these encounters. How are we perceiving these stories, and what are our biases and assumptions when we're coming into this? And so relating to our case, how does Mr. M's intersecting identities of a newcomer, senior, some cognitive difficulties, and any other experience that he had impact his experience and his stories? It also helps us recognize the power dynamics at play. So we have Mr. M that's working with a healthcare encounter. His ability to move and mobilize and do things on his own has been impacted. How does that impact his interactions with the healthcare encounter? Does he feel pressure to make a decision? Is he trying to hold on to more power and trying to the tension within this? So really identifying what is our role when we're entering a health encounter within the power and privilege. How are we impacting that dynamic? And then how will his relationship with power and privilege and marginalization and the power dynamics that he has with his healthcare team change when he goes into a long-term care facility? If he goes into a long-term facility where he's reliant on all his needs, how will that impact? How will that impact if he goes into a space that, he doesn't have access, he isn't potentially safe? And so how he's making that decision-making is really important, because if that decision-making he's making his feeling stressed or pressured to make this decision, it's not within its own, that can also have implications. And that can also have implications with repeated sort of encounters with the healthcare system, what patients are willing to share, what communities are willing to share. And overall, an intersectional narrative lens allows us to shift our thinking to understand, how does our social identity contribute to the experience of the world? It takes the narrative understanding what happened before to help us counter and help us understand how can we move forward that supports an anti-oppression and anti-discrimination lens. So it takes what the experience that we had before under the umbrella of an intersectional lens to figure out how can we move forward that doesn't perpetuate any oppression or discrimination, not specifically to this case, but just in patients in general. So one of the things that how we can do this is it's abstract. So one of the things that we can do to help with us understanding is creating a safe space for patients for storytelling, recognizing the inherent power dynamics when we're telling stories and what we may share, what patients may share. This may take multiple encounters and multiple understandings. And what we want to understand is what is Mr. M's story what was Mr. M's story prior leading to this health encounter? What happened before? In the eyes of Mr. M, how does he understand his journey leading to this encounter? So really from his perspective. It sounds like he had a community, he lived at home and lived independently, and now he's in a position of losing that community. So what matters most to Mr. M in this decision? His independence and his dignity is what we've outlined in the case. And when we're looking at what are the options that we can present, what are options that can be least disruptive to the story? Then as we hear the narratives and we engage in these patient narratives and we're listening to the patient's or patient story, it's important to look at how Mr. M's intersecting identities, experience with systems, and interactions are informing this interaction. So the key to doing this is self-reflection. So when we're thinking about what are my biases and assumptions that are going into this encounter. And so that's why intersectionality on its own is problematic, where we need to combine it with narrative ethics as well and combine it with the context, is we want to understand, am I coming in with biases and assumptions in this encounter? And why am I coming in with bias and assumptions? What's previously have I been taught, have I been learned that's informing this? And then when we're looking at how to support Mr. M, do any of these options that I'm presenting potentially exacerbate any experiences of stigmatization or inequities or barriers that Mr. M is experiencing? And then taking a step further from a system level is what options potentially promote institutional change or justice by addressing some of the structural systemic barriers to healthcare resources. With one patient, we can't solve all of the structural and systemic barriers to healthcare, but we can consider how this can promote a positive change as we move forward. And so how, with this one patient, how can we contribute to advancing a health equity, to advancing an anti-oppressive and advancing an anti-discriminatory lens? And so my experience with intersectional narratives is predominantly in research, and I've used it I've kind of drawn on my research experience to draw it into clinical practice. So I'll describe an example of how we can use it in research and how it can be helpful to specifically identify when we have a research question where we're trying to understand a patient or community's experience with policies, guidelines, counseling, any interactions we have. So sometimes we'll use surveys and interviews. And what a narrative approach allows when we do interviews is it can give us a greater insight into the patient's experience. So as an example, as part of my work at Unity Health Toronto in the Department of Pediatrics, we wanted to learn more about how pregnant people with HIV experience is with infant feeding, given that the infant feeding guidelines within Canada recommend formula feeding. So we conducted a community-based participatory approach, which basically means that we work with the community alongside our entire research process. This includes coming up with our proposal, where we co-develop a proposal, a research question, interview guides, and the people that we're working with as part of our research inform how we conduct the research. So my students specifically, created an advisory board of people with lived experience, pregnant people that had HIV. And so we worked with them in a number of meetings to identify how can we best interact with patients and families that have experienced this to understand what their pregnancy journey is and what the impact of these guidelines are. And so they informed us that focus groups were not the best way to do this because privacy is something that the community valued and understood. So we decided to do interviews. And when we did interviews, instead of asking directed questions about what is your experience with infant feeding or directed questions, created a space for pregnant people with HIV to tell their story. So we didn't just ask at the infant feeding experience, we asked them, what is your story what is your story in general? And so within that storytelling, they'll come up with when they were diagnosed with HIV, when they were pregnant, what that meant for when their previous pregnancies, but prior to HIV, and then their healthcare encounter and healthcare journey. And then we took these narratives and then assessed them using thematic analysis to come up with themes, but also use an intersectional lens to identify if there's any discrimination or stigma or any barriers and that they've experienced, and also what has their experience been with the health system and also their encounter specifically. And so this image was created by my student, Thomas and John, who led the study. And we mapped out their experience from their diagnosis of HIV to their infant feeding experiences. And what this allowed us to do was understand their story, their experiences, and their relationship with the health system, what specifically helped them, what supported them, what was not helpful, and what are their previous experiences of racism and discrimination or stigma that they have experienced that's informing this encounter that may be informing their choices. Then when we look at this from an intersectional lens, we learned that stigma and discrimination among people that had HIV, pregnant people that had HIV, was not just limited to their healthcare encounter. In fact, it was prevalent in the communities and the interactions that they had outside of their healthcare encounter. And sometimes the healthcare encounter, if it was a positive one that recognized this, it actually helped rebuild their sense of self. Versus if the health encounter was a negative one, it often perpetuated that experience. So recognize that when they come into this health encounter, they're not just deciding how to feed. That choice of how to feed their infant is not the prominent choice that they're having. It's based on their experience of previously with their journey with a diagnosis with HIV. So this is one example of how intersectional narratives can be used in research and clinically. And so the key is to, when we're having storytelling, is getting permission from the people that are telling these stories, but also really listening and allowing them to tell the stories themselves. So another thing that we did is after we had the transcription of the interviews, we sent it back if they were willing to see it, sent back the narrative to say, did we understand your story correctly? And please correct us if we're wrong. And so another piece that we did was once we finished the research study, we went back to the community advisory board, we back to the participants and shared our results to make sure that we interpreted their story correctly. And, we're figured out how can we move forward, because an academic article is helpful for the academic community, but it's not really helpful for the public. So we wanted to figure out what are some ways that we can take our learnings from this to help, help your narratives and your stories. So this is part one of my talk. And so in summary, I wanted to just summarize, kind of bring it all together in terms of recommendations. And so it's to identify the intersectional narrative ethics allows for counter storytelling. And what this means is, we think about intersectionality on its own. There's these mainstream stories that we've seen that's been perpetuated by, our learnings. And so narrative ethics allows for another perspective and stories and opens up to other stories and experience we don't usually hear about. It can challenge our biases and assumptions. And it allows for an ethical conflict or a dilemma to be framed from the perspective of the patient and the patient's experience. And so when we pause and think about our biases and assumptions, it highlights our role in the patient's lives and the patient's situation as well. And finally, it gives us an opportunity to identify options, solutions, and resolutions that are co-constructed with the patient that do not perpetuate previous experiences of discrimination, racism, oppression, and systemic inequities. And so this is kind of like looking at the intersectionality from a narrative ethics approach. And so one of the things that also impact a patient's story and a patient's interactions is the language that we use. And the other important part of it, the language that we use when we're working with families from diverse backgrounds, whether we're conducting research, whether we're advocating, writing grants, the language that we use when we're working with these groups, if it's stigmatizing, if it's perpetuating any discrimination or oppression, it can perpetuate these feelings. So language plays an important role in their experience with systems and how they're perceived. And the evolution of language, of equity language, and we've seen this evolution of equity language, is also reflective of the narratives that patients and families and communities are experiencing that have intersecting identities. So I really like this quote that says, language changes as we change. So in the past, several decades, several things have happened around the world. Several things of our understanding of equity, understanding of intersectionality, our understanding of Indigenous specific racism has changed, and it's constantly changing. And so I won't go into the details of this, but this is a snapshot of the evolving lived experiences of communities from diverse backgrounds, particularly Indigenous people, that have resulted in and continue to result in the evolution of language. And so with this evolution is how we advocate for change with each experience. The language you use changes. So we have the Multiculturalism Act that came out, but when we kind of delved deeper into this, we understood that that we use the term visible minorities, but we still noted this as problematic. And then when we looked into the Royal Commission on, when we reviewed our Truth and Reconciliation, our commitment to Truth and Reconciliation, we recognized that the terms that we previously used had a negative impact on Indigenous people and Indigenous families because they were stigmatizing, discriminatory, and also inhibited self-determination. And then from 2020 to 2022, we focused on a shift in language and emphasizing sort of equity deserving, strength-based language. And now I feel like we're in a bit of a reflection stage where there's a greater focus on intersectionality, there's a greater focus on allyship, and it increases and emphasizes decolonization of language. And it's also important to note, and we've seen this for people that work kind of across the province or across Canada, what we use in BC might be different from what we use in other parts of Canada. And this is because it's reflective of the stories that people make up and the diverse communities that make up that community. So some examples of this are, which is not an exhaustive, there's a longer list, but some of the ones that I've worked with that I've typically seen as a change is specifically first in neurodiversity, for instance. So we've kind of seen the evolution from developmental disability to developmental concerns to neurodiversity. And then there's now, we also refer to developmental diversity. And so this changes according to the experiences of people that have neurodiversity around how they've been perceived, their experience with the health system, their experiences of advocating for themselves, and their experience to, not be stigmatized or discriminated against. And so we also see with this, the umbrella term of equity deserving groups, where we went from marginalized, vulnerable groups to equity seeking, to equity deserving. And now there's a bit of a change with unrepresented or equity denied groups. And though this shows based on our experience with these terms and based on hearing from the community and their experiences with the term and engaging with the community more, we see how previous terms have potentially been more problematic. And then we also see this cultural competency and cultural sensitivity, where it's now, it's not about being sensitive to one's culture, but it's really about understanding cultural safety and understanding cultural humility and understanding what the experiences of equity deserving groups are. And so what a common theme is with this shift is it's gone from more deficit-based to strength-based. And this reflects on the stories and situation where prior to, early on with equity work, where we were in a stage of advocating and identifying and unpacking the health equities. And now we're shifting to more empowerment and working with communities to work together to support each other and build up communities together. And so there was a literature review conducted by Fernandez et al. That reviewed terms related to characters of specific groups based on race, ethnicity, gender, sexuality, disability, and communities in the following national documents that I've listed here to see what language are we using and how are we using them. And so the groups that were involved were migrants, persons with disabilities, persons living with HIV, people experiencing homelessness, or unhoused is a term that we commonly use now, persons in custody, persons who use drugs, people with mental health disorders, older adults, persons of various racial identities, and persons with LGBTQ plus identity. And in this analysis, Fernandez Sanchez found that the importance of, it was varying within all the documents, but they highlighted the importance of inclusive language and preferred terms. And what that means is the preferred terms within that community, within that specific situation. avoiding advocating for person-centered language, and I'll talk a little bit about person-centered language means, and non-stigmatizing language. So when we're using descriptors, using describes, whether we're writing in our chart, where we're writing grants, are we further stigmatizing the groups that we're working with and discussing? Overall, the terms that we use, we want to focus on promoting dignity, respect, inclusivity, while balancing the diverse needs and identities of the patients and families we work with. So his overall recommendations, and also based on kind of what's going on with what's going on with the landscape of equity language, is using person-first language with descriptors. So it does take a little bit longer to describe them, but I think the context is really important to avoid stereotypes and reflect and avoid discriminating terminology. So being open and curious to if there is language that we're using that's discriminating to certain groups or communities, understanding why and reflecting on what we can do to change. So focusing on the dignity of individuals and avoid identifying groups by their impact. So there is a shift to saying we are not defined by our impact, we are not defined by our experience, we're people first and our impacts are our experiences. So for example, using terms like communities made vulnerable by, populations marginalized by, or experiencing marginalization, focusing on this. And so ongoing review for self-identification and self-determination is important. Overall, focusing on strength-based approach. So when we're writing these grants or research papers or any other languages, when we're writing, when we're doing speeches, focusing on strength first, and actively speaking to the community and being open to reflection is really important as well. Because the community, when we use these terms in language, the communities are impacted. So if they're negatively impacted by the terms that we're using, it's important to engage and understand why and shift our thinking according to be inclusive with the community. And so I just wanted to acknowledge the work that and the experience that I've gained. I could not have done it by myself. And so I want to acknowledge PHC Ethics Service and the Department of Pediatrics and at Unity Health Toronto as well. Thank you for listening. So I'll stop. I'll just put my contact information if anyone wants to contact me for anything else, and I'm happy. And I kind of put snapshots of the work that I've done because I don't have a lot of time. If anyone wants to hear more about that work, I'm happy to chat.
Perfect. Thank you so much, Thivia. It's a really interesting and important presentation, and it's definitely given me a lot to think about. So if anybody has any questions for Thivia, I encourage you to put it in the Q&A portion there. Try and put it in the Q&A and not the chat, just to keep everything clean and sorted, and we can answer your questions. But before we get to that, or I just want to start us off with a couple questions here. And the one thing I was thinking about, kind of connecting the two parts of your presentation with the narrative ethics and the evolution of language and everything. I was wondering if you can speak a bit more about the importance of, you talked at the end about the importance of engaging with the communities around the language that they want to use. And I wonder if you had any advice or insights about how to approach those situations where sometimes they might differ. I'm just getting messages that apparently the Q&A is not working, so we can just put it all in the chat. That'll work too. But specifically what I was thinking, so I'm a PhD student right now, and a lot of my work involves people in the disability community. And in that community, there's been a shift from saying disabled people to people with disabilities, using that person first language. And now something that has been coming up a lot more and is being expressed to me is people saying no, we want to use the term disabled because it draws attention to the fact that society is disabling us, right? It is a process that is happening. And so wondering about the way that, if you could talk about the way that language shapes and is important to the narratives within different communities, and how do we approach situations where maybe there's a difference within these communities of how people, the terms people want to use.
Thanks for bringing that important indication. One of the things that I usually mention, but I didn't mention this one, is what the balance with the person-centered language is also that it's also how sometimes naming the impact helps with advocating and helping with getting resources and accesses. So similar to what you said in the disability community, in neurodiversity, for example, sometimes you need that definition of developmental disability or developmental diagnosis to advocate for yourself. So what you pointed on is key, is knowing that one term does not represent one community and represents multiple communities. And so by working with that community and talking to the community and getting the different perspectives, including both of those different perspectives, makes it a more inclusive experience. Because it's also depending on within disability, for instance, there's different levels of experience that you have with disability depending on other intersecting identities. So with different intersecting identities, you have a different experience of disability and the way that you perceive and want to be referred to. So I think it's expanding your toolkit and toolbox to include all variations of it, and doesn't necessarily mean that they conflict or one is better than the other, but it's inclusive of the diversity of the community itself, and it identifies that we're not identified by one thing, we're identified by multiple things.
Yeah, thanks. That's really helpful. That makes so much sense. And just thinking about that wheel of power that you showed there earlier, and the way how like every person is, nobody is located at exactly the same point on that, right? We all have our own different narratives and how that shapes our approaches to these things. Another question I had is how maybe those of us working in the clinical space can create space for these narratives, and also like maybe creating space for narratives to change. So the one thing I was thinking about in your example with Mr. M, we see often sometimes where like somebody has a narrative of they're like, I am a strong, independent person living on my own. And then, like you said with Mr. M, something happens and they go into care right away, right? And that's I think that I really like the word you used of rupture around that, right? Because it's that break in the narrative. And so yeah, just wondering if you could speak on how we as clinicians can create space both to honor that narrative that they're coming in there with, but then also maybe creating space for that narrative to change, like maybe allowing Mr. M time and space to come to the realization that maybe long-term care is a better fit for him or something like that.
I think and I know it's hard when we're pressed for time and we have time constraints with our encounters, but I think it's figuring out who on your team, on your role, has the capacity and has a role and has the ability to continuously interact with Mr. M. And kind of seeing him beyond his numbers, seeing him beyond his clinical picture and seeing him within his story. So it's continuous interaction within the patient narrative. And also, I think also recognizing our biases and assumptions we're going into that encounter. So if Mr. M is describing himself as independent, strong, and that's how he perceives himself, but we see otherwise, that doesn't necessarily mean we're wrong or Mr. M's wrong. But when we look at this from the patient perspective, they still see themselves as independent and strong. So it's honoring what that means to them, and that definition of independent and strong may be different from our definition of independent and strong, but how can we preserve that identity that they have over time and allowing for that narrative to change? And so just because there's a difference in opinion in terms of the narrative doesn't necessarily make it less right or wrong necessarily, but it's giving that space for us to understand what his definition of independent and strong means versus our definition of independent and strong. I hope that answers the question. I kind of went circular, but
no, totally. That makes a lot of sense. And I guess it's such a kind of tricky thing to negotiate and to be able to even get at, right? Because I think a lot of people can often come in with their guard up, very justifiably so, and like maybe aren't wanting to open up their narrative. And I think maybe that leads nicely into the next place where I was wanting to go, is the narratives that we carry in, like as people who work in healthcare, and how that can clash with these things. Wondering, there's a lot of people who, I think you did a good job of highlighting how people can come in to healthcare with a lot of very justified distrust or have their guards up, and there's the narratives of like hurt and harm and and real damage that's been caused in the past. And then as people who work in healthcare, sometimes we can go into these situations being like, well, that's not me, I'm one of the good ones, I'm trustworthy and stuff, right? So I guess what advice would you have for people working in healthcare to be able to allow those narratives to change for themselves and to approach those situations as well?
I think that's a really good question, and this comes up a lot when we're talking about equity and health equity and systemic barriers. I think the first one is to look at it from the patient's perspective and not from our perspective. And our discomfort with that situation is looking at it from the patient's perspective. What experiences does the patient have that specifically, not directly at you as the clinician, but specifically that's informing this decision making? And then also understanding that the experiences that Mr. M is bringing is not a reflection of you as the individual, but it's a reflection of the systems that we're working towards. So if Mr. M is experiencing, you walk in, experiencing distrust and doesn't trust you, it's not specifically you as a person that he's experiencing distrust with or attacking you disengaging with you specifically. It's the system that has resulted in that mistrust. So how can we turn around that system as an individual? So it's as an individual to help be more supportive. So it's being, I think Ali, my colleague, often uses this, soft on people and hard on the systems. So I think when we're going to that encounter is trying not to take it personally and taking a step back and understanding what the systems are.
Yeah, I think that makes a lot of sense. That's yeah, it can be hard in those situations when it often feels like it's directed at you as a person, when really it's a response, and often a very justified response to these systems and everything, right? And yeah, I think also too the way that really I appreciate how you highlighted like what is the patient's experience in that, right? And it's not necessarily about you want to do your best as a healthcare worker in that situation, but at the end of the day, it's about what does the patient need and what's going to be best for them and everything. So we got a question in the chat here and says, it seems to me that a key component in Mr. M's narrative as a current reality is his community. If he had said family, we might easily pursue this, but sometimes we need to listen with open ears and be prepared to explore a surprise, in this case, the community. Do you have any comments on this?
I think if I'm understanding the question specifically is I think the understanding of like the importance he places on community versus family.
Yeah,
If I'm
I think
understanding
so.
the question quickly. Yeah. I think it's also it's reflecting on what other people and other story, what they define as family and community and what's important to them and the terms that they use. So for Mr. M, community could include family, could include other people. And so while some people may provide importance to specific family as an important reason to stay together and connected, other people, that family might be a definition of a larger community as well. So I think, recognizing that people have different experiences and understandings of their sense of relationships and relational nature, and understanding that would be important.
Yeah, thanks. That makes a lot of sense. There's so much that goes into shaping everybody's responses to
Relationship.
everything, right?
Yeah.
Yeah, absolutely. So we have going to move on to some announcements and stuff here right away. But before we do that, I just want to highlight Melissa posted in the chat and just said, thank you for your excellent talk. You mentioned reflecting on biases and assumptions. Have you looked at beyond the binary? And then includes a link there. It says, well, it's aimed at the research community. It offers perspectives on gender inclusive language that I think are also relevant to healthcare. So there's a link in there if anybody wants to follow that. And so, yeah, I just want to take a minute and thank you again, Thivia, for this really excellent presentation. And thank you, everybody, for joining us here today. It's a really important topic. And I think, yeah, you've just done a really beautiful job of highlighting like how complex healthcare is and the narratives that we all carry in it with us from all these perspectives, and the complex nature of like how the language evolves over time, how we as people evolve over time, how patients' understandings evolve over time, and the importance of creating space for that in here, and how that can really, help have the best outcomes for everybody involved. So
Absolutely.
thanks again, everybody. Just have a few announcements here. So please ensure that you complete the post-event survey following this session. It's really helpful for us and for our speakers to know what you want to see more of, what you thought of today's sessions. So there'll be a link in the chat for a survey that you can fill out. And it really helps us shape our ongoing sessions and know what you thought of this one. I also want to highlight that we are going to be hosting our annual 4-day ethics seminar from April 20th to 23rd, and our 1-day annual ethics conference. So links to the events and to the registration pages will be put in the chat there as well. I meant to do this earlier. I'm just going to share a slide. Maybe too many things. Okay, well, the slide I'm supposed to share is popping up and blocking my whole screen, so maybe we won't do that. Where did you guys go there? Share. There we go. Now it's up. And also, we're excited to announce that our next session of Ethics for Lunch is going to be March 18th, I believe. And that is with Alexandra Almos Perez and Kathleen Johnson on the topic of power and privilege. So please watch your email for those details, or visit our website to sign up for the email if you haven't already. And yeah, thank you everybody for your time. Please join me in thanking Thivia for her really excellent presentation. And yeah, enjoy the rest of your day. Stop sharing. Thank you, Thivia.